Hello, I'm Dr. Omar Bay, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we're talking about a great topic tonight. It's called inflammatory bowel disease. And I think it's a wonderful topic to go over because so many of us are afflicted with this. But before we start, I can't forget, I would like to talk about our sharing and caring, because it's all about letting me know on the email what's going on, what's happening out there as far as your medical. And so we on this show can come back and do shows that can improve your health. Remember, www.medmoments.com. And tweet me at medmoments. So that's www.medmoments.com. That's the email address. Well, let's get to our topic tonight. It's called inflammatory bowel disease. And I have a physician here to cover this topic. We're going to cover A to Z in this particular topic. Our doctor his name is Dr. Godwin Maluku, and he's a gastroenterologist. Dr. Maluku, welcome to our show.
Thank you very much.
Oh, it's a pleasure. It's a pleasure to have you here.
Thank you.
All righty. So, as usual, I start off with my basic question, and that is, what is inflammatory bowel disease?
Exactly what the name says, inflammatory bowel disease, an inflammation of the bowel.
Mm-hmm. Now, when you say inflammation, what do you mean? Do you mean swelling?
The swelling, redness, comes with pain, redness, erythema, has a lot of manifestations, and there are two groups of inflammatory bowel disease. We're going to get to that.
Okay, all right then. Now, how do people get this particular disease? Is it something that I would catch from a virus, or is it something that, you know what I mean, if I ate the wrong thing, I'm going to get it? Why would somebody get an inflammatory bowel or an inflammation in the bowel?
Well, Dr. Bay, you'd be surprised to know that no one knows. It's an idiopathic process of inflammation involving the bowel.
Okay.
It would have been nice if we know what is the cause of IBD.
Okay, so when you say idiopathic, that means without knowledge?
Nobody knows.
We don't know?
We don't know.
Okay.
We believe that there's a lot of theories out there, depending on who you believe. But when you look at the treatment of IBD, it's also known as IBD, inflammatory bowel disease, the short form of it. Most of the medication that we use is channeled through inflammation. So we're going to get to that. But as of now, no one knows the cause of inflammatory bowel disease, known as IBD.
Alrighty. Now, is there, once you know that you have inflammation of the bowel, what are the symptoms that I may experience as a patient? You know, if they came to your office, what would they be experiencing?
Well, history is very important. Okay, family history comes in play. It depends. Okay? Are we talking about the Crohn's disease, which is one arm of inflammatory bowel disease, or the ulcerative colitis? Because the manifestation is a little different. Okay. Some people comes in with abdominal pain. Some comes in with fever. Some comes in with diarrhea and bleed. You need to be very careful. And that's why I say history is important, because infectious colitis can also manifest like IBD.
Okay, so you just said something there that really piqued my interest. Now, there is a infection, like if there's an infection in the bowel, you can have similar symptoms, but what you're telling me now is that inflammatory bowel disease is not infection.
No, it's not. That's very important, because you have to rule out infection. And this is where history becomes very important. History of recent travel, history of exposure to antibiotics, history of getting involved in something that could have caused bowel problems. So you need to get history, because the treatment is different. I don't know if I should go into that, but however, we'll get to the treatment of IBD, and then we'll get to treatment of infectious colitis.
All right then, good. Now, what are some of the risk factors that may cause you to get something like this? I mean, I know that everyday stress and people, you know, your bowel is going and it's telling you that it's there, and you may have a little a pain in the stomach area or in the lower part of the area. But what are some of the risk factors that may cause something like this?
family history is important, age is important, and history of exposure. Some people, a typical example was one of my patients who never had bowel problem, was traveled outside the country, ate some food. I mean, when you listen to the story was so good for infectious colitis. And that was the beginning of IBD in this gentleman. So, well, there are theories that stress can basically suppress your immune system or can change the makeup of your immune system, and all of a sudden your immune system will begin to look at the bowel as a foreign object in your body and begin to attack them. Remember this, that the cause of IBD is unknown, but we believe that it was due to possibly immunological response to some changes in the bowel.
Alrighty, so let's just step back because that's very interesting. What you're saying is that there may be a factor or a molecule or something in our bodies that perceives or thinks the bowel, that part of the bowel, which we're talking about, like the colon or whatever,
that's correct,
is a foreign body, so it's trying to attack it.
Yeah.
That's so correct. That may be one of the reasons that we're having the
theories out there. That's correct. And the treatment for IBD, again, short form of inflammatory bowel disease, is targeted towards the immunological response. Okay, when you look at the treatment, is anti-inflammatory. Okay. We know the bulk of the cause of IBD is due to inflammation. Okay, and most of the treatment, whether the pro drugs, or processed drug, that they act topically in the bowel itself. Most of them are not even absorbed.
Right. Okay. So what you're saying is that they just go there and they work on the outside layer of the skin.
That's correct.
And to decrease swelling.
Decrease swelling, decrease inflammation, decrease redness. Right. And then hopefully the system will heal itself.
Okay. Step back just for a minute. Let's just get a little basic here.
Sure.
Tell me about the bowel. How is the bowel made up? I know that there's the anal region or the rectum or the anal at the end, and then from there it goes back to colon and stuff like that. How is it? Tell me about this.
Let's start from the oral cavity, from the mouth. Okay, there's a different part of the bowel has different linings and different muscular makeup. The esophagus is different. The proximal part of the esophagus is the muscular makeup is consistent with the oral cavity, the pharynx, the oropharyngeal muscles, and then down to lower two-third, which is smooth muscles, which is in continuity with the makeup of the stomach. And then stomach is a bean-shaped muscular in itself, can take a lot of resistance and insult, produce a lot of acid, which helps to kill bacteria, get some stuff active to be absorbed. And then the small bowel. Okay. The lining of the small bowel all to the colon are pretty much the same. Right. The small bowel has a unique function because most of the absorption takes place in the proximal small bowel, and some minerals and elements are absorbed in the distal part of the small bowel, known as the terminal ileum or the ileum. And then the ileocecal valve, which is I like to look at ileocecal valve as a barrier, that anything proximal.
Okay, you jumping out here with these big words, and I love it. But when you say proximal, you mean before the ileocecal valve. Right. And the ileocecal valve is that valve where you get the small bowel,
the end of
the small bowel going into the large bowel.
Right, the beginning on the other side.
Okay, and the large bowel is called the colon.
The large bowel is huge.
It's huge.
I mean, the length. It's unbelievable. And they do a lot of functions. But let me take you back to small bowel, because this is very important. And you see why history is very good. Most of the absorption takes place in the small bowel.
Now, when you say absorption, we're talking about when we eat something, minerals, like the fats and the glucose or the sugars and the proteins that we eat. That's where it's absorbed.
It's absorbed in there, and then left over, if any, especially the water, colon concentrates, and 20% of the water is absorbed in the colon. Okay. And it uses a pathway known as sodium potassium ATPase pathway. Right. So you need that pathway in order to absorb them. What that means is this: by the time these two, the feces, get to the colon, most of them, if not all of them, about 80% is already formed.
Okay, so what you're saying is that our stool or our bowel, our stool, I should say,
Right.
Once it gets to the the colon or the end of this long journey,
Right.
it's the basic consistency of what's in the bowel is already formed.
Right.
It's formed. So the water is already extracted. Yeah. When we have a bowel movement, that's already formed once it gets to the colon.
Yeah, about 20% of the water is absorbed in the colon.
Okay.
And it uses a sodium potassium ATPase. It's a pathway that helps absorb water. And so if it becomes important when we talk about the diarrhea, the mechanisms and all of this, you see why history is very important, because when the patient tells you, even by history, you could tell where the pathology is. Mm-hmm. Is it small bowel problem or is it a colonic problem? Mm-hmm. And right there, you can be able to draw your conclusions or inference, and then treatment is different. We're gonna get to that.
Okay, let's jump right into it. Sure. Then. Let's start talking about ulcerative colitis.
Okay, very
good. Alrighty. What exactly is? I know there are two types of inflammatory bowel disease: ulcerative colitis and Crohn's disease. So let's start off with ulcerative colitis. What is this?
It's an idiopathic inflammation of the colon. Okay. Mm-hmm. Idiopathic means, again, we don't know the cause of it. Mm-hmm. It manifests differently from Crohn's disease. However, ulcerative colitis exclusively involves the colon.
Okay, the colon is the last part. That last part of the bowel. Yeah. Okay.
And we're talking about the rectum. Mm-hmm. Some people say the anus, the rectum, the sigmoid colon. Mm-hmm. Okay, rectosigmoid angle, the descending colon, the splenic angle, and then the transverse colon, which is huge, to the right side of the colon. Mm-hmm. So ulcerative colitis present with superficial ulcers, to some degree deep ulcers. It doesn't involve what we call the transmural. Okay, there's a different manifestation when you look at the Crohn's disease. The entire colon can be involved, or there will be a segmental involvement, meaning that, and again, it's very important because when you look at Crohn's disease, you see why ulcerative colitis is different. Crohn's disease can also involve the colon to some degree. Ulcerative colitis can exclusively involve one part of the colon, and the rest of the colon are normal. Mm-hmm. Okay? Known as segmental colitis. Right. Okay, let me throw in Crohn's here because it's very important. Crohn's can have patchy areas of inflammation, but can spread around the colon. Mm-hmm. Okay, so ulcerative colitis exclusively involves the colon. It does not involve the small intestine.
Okay, so just to summarize here, the ulcerative colitis means that there are ulcers in that last part of the bowel called the colon.
Yeah, with background inflammations.
Yes, and swelling around.
Swellings around. Yes,
and from there you can get bleeding. You can get
abdominal pain. You can get tenesmus. Feel like you want to go all the time.
Like you want to take a bowel movement all the time.
Yeah, and you can get bleeding, rectal pain. I mean, the presentation is huge, and people could have fever.
Fever as well. Yeah. Now, how does Crohn's disease different? What's different about it? I know you said it can involve the colon in patchy areas, but tell me about Crohn's disease.
Crohn's disease, some people call Crohn's the big evil, in the sense that it can involve any part of your alimentary canal, any part of your digestive system, so from the mouth to the anus.
So all the way through, it can involve.
Yeah, it can involve. And most of the time it involves the small bowel, the distal part of the small bowel.
So the distal means the far part, the last part.
The last part, closer. This is very important because it's closer to the colon. It's closer to the ileocecal valve.
Right.
Okay. And it presents. It could exclusively involve that part of the small bowel by itself. It can involve that part and the stomach and the oral cavity in form of ulcers. Many people can present with just oral ulcers, and they have ulcers in the mouth, and they could be diagnosed with Crohn's disease. History is very important.
Okay. Right. Now, does that have the abdominal pain or the stomach pain as well?
They do present with abdominal pain. The manifestation is huge. Some people say it's even worse than ulcerative colitis because it can present with pancreatitis, inflammation of the pancreas. Yes, it can present with fever, intestinal obstruction. It can present with diarrhea, obviously, because small bowel is involved. So it can present with huge, some people can even bleed if it crosses over to the colon, which it does have.
Then
yes.
you get some blood in your stool. Like when you have a bowel movement, you'll see the blood in your stool.
Yes, correct.
Interesting. Now, is it more common in older folks, or can the young get these problems as well?
Yes, they are bimodal distribution in age group, but it's disease of young people.
Okay.
Begins with 15 to 25 age group.
Okay, you just threw a big word out there.
Yeah.
Bimodal. This doesn't mean it
right.
comes in an early part of life and then it leaves you later, and then it comes back later.
Yes, that's correct.
All right. Excellent. Now, what about things like cancer? Can cancer come about because of this disease? Or either of these diseases?
That is one of the concerns long term when you have chronic condition from this. Ulcerative colitis, the history says, as a matter of fact, that if you have this disease for close to 8 to 10 years, there's an increased risk of cancer. Both, a typical example, both small bowel cancer, lymphoma, and colon cancer in the large bowel. Okay. And then cancer of the what we call gallbladder area, the liver, the ducts that come out of the liver can also manifest with some cancer, cholangiocarcinoma.
Okay.
Yeah.
Now, the thing of it is, you said that ulcerative colitis over a long period of time can be associated with cancer.
Colon
what about
cancer.
The colon cancer? I'm sorry.
Crohn's
disease.
Crohn's disease.
Right. I just wanted to clarify that. What is it? Ulcerative colitis or Crohn's disease? Which one actually is truly associated with cancer?
Ulcerative colitis.
Ulcerative colitis.
Yeah.
Okay. So
colon cancer.
For colon cancer.
Yeah.
All right. Is Crohn's disease associated with any cancer at all?
Yes,
or that's
small bowel cancer.
Oh, that's the one with small bowel cancer.
Yeah.
So around
lymphoma.
Okay, and that's the one where the ileum, that distal part, or that last part of the small bowel is where most of the problem can arise.
That's correct.
Excellent. Well, what as far as what we eat, can that cause these diseases to come about if you eat certain things? It's like if you're a big meat eater, or you know what I mean, you don't eat one particular type of food or something like. Can it cause these diseases?
It's an idiopathic cause.
All right,
but it can aggravate
or it can
underlying disease. Yes. Yeah.
Okay. All righty. What about as far as gender? As opposed to males or females, do one or the other get it more?
Share the same risk.
Same risk. So men are just as likely to get it as a female.
That's correct. That's correct.
Alrighty. Are there markers that we can use, or you can use as a doctor, that I can draw some blood and say this person is going to have ulcerative colitis, or this person's going to have Crohn's disease?
There's a histocompatibility there. If you look at the family history, we measure what we call the HLA. You can measure some. There's some blood work that suggests that someone is at increased risk.
Okay.
And it runs in the family. So if you look at the Jews and non-Jews, Jews are more predisposed to this disease. People from the so-called, even the developing countries and undeveloped countries. Developing countries has more people diagnosed with IBD than developing countries.
Okay. Now, when you get this, is it always a chronic problem? Can you get rid of it? Can it go away?
No, it's a chronic condition, manageable with medications, surgery. I mean, there's a lot of stuff that we can do, and we know that. If we can go into management if you want to talk about it, or we can discuss that later. But yes, it's a chronic condition. Right. It's idiopathic, but it's manageable.
Okay. Now, I know that certain segments of our bowel allow us to absorb foods.
That's correct.
Do the patients lose weight, or are they malnourished after a time?
They can manifest with weight loss, anorexia, and they could be malnourished. They can. I mean, you could look at them because lack of absorption. If that part of the small bowel that absorbs most of the nutrients is involved, they're going to have problem absorbing nutrients and minerals. And then some of them will have chronic bone pain. And not only that IBD involves the bowel, it does also have extra intestinal manifestations. Some people can even present initially with skin manifestation suggestive of IBD. So if you're a doctor who is exposed to this disease, you can make diagnosis. Could you believe that, we talk about diarrhea. Some people present with rectal bleed and constipation. And they have IBD. Again, inflammatory bowel disease. So, yes, history is very important and presentation can vary.
Okay. Right. What about things like, as far as I understand, I was reading something that said that cigarettes had an association with this particular problem?
Yes. We know that, again, some of my colleagues disagree. Smokers, Crohn's disease, less ulcerative colitis. That's correct.
So a smoker is more likely to have
Crohn's disease. That's correct.
But he's less likely to have ulcerative colitis.
Yeah.
Interesting. What about occupation? Like I go to my job and boy, every day, my boss is just screaming and screaming, and I'm just like over the top.
Stress. Stress can suppress your immune system. We know that. And the immune system is basically what keeps us in check. And so stress can twist your immune system around, decrease your immune response to regular or daily stuff that we're exposed to. And all of a sudden, your immune system will look at your bowel, your part of the body as foreign and begin to attack them. That's correct.
Yes, sir. Interesting. Now, tell me, how do we diagnose this? I mean, you have somebody come into your office. They're obviously having bloody diarrhea or abdominal pains, or they're having some fever. So what do? Do you collect stool samples and send them off, or do you take them to the lab? Take them to the OR and do endoscopy or something, some procedure? What do you do?
What I do in my practice, and I do have a big practice in the area, is first, history is very important. Somebody comes in, let me give you a scenario. Diarrhea, tenesmus, abdominal pain, fever. You could see them in infectious colitis, known as enterocolitis, what I like to call them, because they do have manifestation of the upper GI complaint. What I want to know from this particular patient is, did you travel outside the country? What happened within the past few months, few days? Does anyone in your family have the same problem in the past? So history will guide you. If they said no, then you still have to check the stool, because you want to rule out infectious cause of bowel problem. And then there's a lot of stuff you can do. You can do x-rays, you can do endoscopies.
Endoscopy is to look at the scope going down, or the scope that comes up from below?
Correct, because the endoscopic find is consistent with each and every one of them. And then you can do biopsies. You can do, but then it's known as CD, the Crohn's disease antigens that we can send out now, and they come back suggestive. We call them CDX index. Yeah, you can send them out, and they come back, especially for Crohn's disease, and they come back and they're diagnostic.
And they'll give you some indication that this patient has that problem. Alrighty.
And then you can
go ahead.
Then you can channel your treatment, but you gotta rule out infectious cause.
That's the most important.
Very important, because, and you're going to see why, because we begin to talk about anti-inflammatory and the use of antibiotics in this disease.
All right. So the treatment is actually, when we start getting the treatment, it's things that would decrease swelling.
Yes, anti-inflammatory response.
And antibiotics to make sure that there's no infection.
Right.
And on an ongoing basis, this would happen, or?
Yes, the patient can go on for years, disease-free, and then boom.
They come back.
They come back again. I have a gentleman, like I told you, who went to Dominican Republic with his girlfriend, and never had these symptoms before. They went out there, they had some good time, and came back with, she didn't get sick, and they were, bubbling and mumbling and all that. Young people, ate from the same plate, and she did not get sick. He got sick, and now this is a chronic condition. We rule out infectious etiology, and he's been treated for IBD. which is going to be a lifelong illness for him.
Right, right. Well, Dr. Maluku, thank you very much.
Oh, you're welcome.
Thank you very much for coming and explaining this to us. It's a very interesting and very difficult topic.
It is a very difficult topic, yeah.
But I think, you know, it's so important that we have an understanding, because I truly think so many people are affected with this.
That's correct.
Thank you very much.
Thank you.
All righty. It's time for our Let's Talk. We only have a few minutes to talk about it, but I wanted to talk about healthy meals. And what we're talking about, I'm talking about eating healthy and doing the right thing as far as what we eat, because we are what we eat. So we want to eat more vegetables. We want to do more fruits, smaller portions, everybody, because the larger the amount you eat, the larger we become, because we are what we eat. We want to get those proteins in as well as our grains. Well, our time is out, and I would like to say that this has been a wonderful, wonderful show. But in closing, I would like to say, don't forget sharing and caring. www.medmoments.com, and at MedMoments, you can tweet me. So email me or tweet me. All right. Never institute any change in your medical therapy before you consult your physician. I trust that each and every one of you have continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all. All righty, Dr.
Thank you, Doc. Excellent.
Excellent.